Hi, I'm Dr. Susan Chandler of the Integrative Health Program at Massey Cancer Center. With us today is Jodi Cunningham, nurse practitioner for the Survivorship program at Massey. She's going to talk to us about living with pain after a cancer diagnosis. Jodi, we're so happy to have you with us today. And I would ask anyone that's viewing live, if you have questions, just enter them in the chat box, and at the end of her presentation, we'll address those. Thank you. Hi, Jodi.
Hi, Susan. Thank you for the introduction. So as Melissa's getting the PowerPoint pulled up, I'll just introduce myself. So I'm Jodi Cunningham. Like Susan said, I'm the nurse practitioner in the Adult Cancer Survivorship program, which is a new program here at Massey. Hopefully you've been able to tune in with some of the talks from Dr. Susan Hong, who's our director, who has been building this program just since January. So we're happy to get the outreach and get to know our community and reach out to you guys to see what you're interested in learning about and how we can help all of you in the community. So like Susan said, we're going to be talking today about living with pain after a cancer diagnosis. And first, I want to introduce our team. And I did already mention, I'm the nurse practitioner. We're a small team, but I like to say we're small but mighty. We have Dr. Susan Hong, who you can see pictured here in the middle. She was recruited here specifically to build this program here at Massey. Myself, and then Eunice, our nurse, is the glue that keeps us all together and keeps us moving forward. And we take care of patients as early as diagnosis, throughout treatment, and for the entirety of life. So if you've ever, even if you're a brand new diagnosis or you've been dealing with cancer or on surveillance for years and years, we are happy to see you and have you join our team. We also see patients that have high risk from genetic mutations that put them at high risk of cancer. So if you ever have any questions about that, at the end, you'll have my contact information. So today we're going to discuss a few things. First, we're going to start with what is pain and talk about the different types of pain. We're going to review factors that contribute to pain. We're going to learn about the treatment for pain. We're going to discuss the risks and benefits of pain treatment. And then finally, we're going to talk about the resources here at VCU that you can tap into for pain management. So what is pain? Well, according to the Oxford Dictionary, simply put, pain is physical suffering or discomfort caused by illness or injury. But more specifically, and more related to cancer, the cancer pain experience comes from a definition of the International Association for the Study of Pain. And this defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And some highlights that kind of go into this definition are that pain is a personal experience and it's influenced by many things. That could be biological, which is simply how your body is made, how you metabolize drugs. Psychological, which could be related to experiences you've had in the past with pain, or if you have other things going on, such as low mood. And then social factors. So social factors are the environment in which you live, how your access to getting pain medication for related to monetary factors and things like that. So it's a personal experience and it's not the same from person to person. So it's really important that us as clinicians treating pain have a really good understanding of everything that goes into your pain experience. And it's also important to note that individuals learn the concept of pain through life experiences. So again, this looks very different for everybody. You may be a woman that's delivered a lot of babies naturally. And so you have been through pain and you've experienced pain in that way. You may be somebody that's actually never experienced pain outside of like a stubbed toe. So, and also seeing pain through the experiences of loved ones can influence your experience with pain. But kind of in a very simple sense, and what I like to tell patients is pain is the body's way of telling you that something simply isn't right. So there's different types of pain, and I think it's important to understand these because a lot of times in healthcare, we'll use these terms and we don't always do a good job of explaining them. So here we'll review some different definitions of types of pain. So there's acute pain, which anytime we say acute, that's short duration. So that's lasting up to 3 months. Chronic pain, so anytime we say chronic, it's pain lasting 3 months or more, or any kind of chronic condition, 3 months or more. Neuropathic pain, or also known as nerve pain, is caused by damage to nerves. And this can be described differently than other pain. This is described as shooting, stabbing, burning. Sometimes people say it feels like pins and needles, or that sensation similar to what you get if you hit your funny bone. And neuropathic pain can affect things such as sensitivity to touch. So if you put your hand in the freezer to grab something out, you might notice a little bit of pain because this nerve pain is caused cold sensitivity. And there's also a phenomenon called phantom pain. And phantom pain is when, for example, you have to have a limb removed for whether that's cancer related or any other reason, that patients will actually still have pain in the limb that was removed. And that is real pain, and we do treat that. Nociceptive pain. So you won't hear this term quite as much, but this is sort of that general pain. We have, this is our normal pain receptors are called nociceptors. So nociceptive pain is pain caused by direct damage to tissue from things such as injury, and also things such as tumors. And then radicular pain, I put this in here because a lot of times you might see in your chart pain with radiculopathy, like low back pain with radiculopathy. And what that means is that pain radiates. So if you have low back pain with radiculopathy, that means your back pain radiates, perhaps down the leg most commonly. So next, we're going to kind of talk about the cancer pain experience. And as I mentioned, kind of going through the definitions, this is not the same for every single person. And so it's important that we don't treat each person the same. But I also first wanted to point out that not everyone with cancer develops pain. But cancer itself can cause pain. Again, it's the body's way of saying something isn't right. A tumor growing isn't normal. That's not right. Your body's telling you something's not right. Cancer treatment can help take the pain away. If you have a tumor and you're given treatment, whatever that is, whether that's chemo, radiation, surgery, and the tumor is removed or has shrunk in size, that in itself can take your pain away. However, treatment can sometimes cause pain. So that nerve pain or neuropathy can happen from certain chemotherapies. Pain from surgery can happen, just like with any surgery. And then radiation sometimes can cause pain too, though that's generally shorter term. And if you have a chronic health condition prior to your cancer diagnosis, that can also impact your pain experience. For example, if you have fibromyalgia, you might have a low pain tolerance, and that's just how your biology of your body is. So you may have a lower pain threshold. Or if you're the woman that's given birth naturally to a lot of children, maybe you have a high pain threshold, and that impacts your experience. We also all might have different tolerance to medications, and this is biological, and then also based on experience. So we do know that some people metabolize certain drugs faster than others and some slower than others. And the only way to find that out is when we try a new medicine. There are some tests that are not approved by insurance, unfortunately, where we can look at that specific biology of patients. But usually we kind of find out as we go through and try pain medications with patients. And pain can sometimes persist even after the cancer is gone. And that's when we get into that chronic pain. And that's can be sometimes difficult for people to work with, because if their cancer is gone and they're still experiencing pain, that can remind them of their cancer, but there is help in treatment for that as well. I really want to point out that there are factors that can contribute to pain, and both of these factors require extra attention in treatment. I see a lot of patients in my practice that have poor sleep, and we do know, we have evidence to show that poor sleep can increase your sensitivity to pain. So you already have pain and now you're not sleeping. Well, your pain can actually worsen because of that. But it's a catch-22 because the pain might be the reason why you're not sleeping. So it's important that we're also treating sleep as well as pain. And our first line treatment for sleep is not medicine. And I hope that as we get through this talk today, as we build your toolbox that we're going to talk a lot about, that you're not always thinking, I want a pill for that, I want a pill for that, because there's a lot of things that aren't medications that can really help you in a lot of ways. And helping with sleep is no exception. So sleep hygiene is really important. And so you've probably heard this term, and if not, I encourage you to look it up. And so this is making sure that you don't go into your bed to sleep until you're actually tired, limiting your screen time, especially as it gets closer to bedtime. And those are just a couple examples. We're going to talk a lot about mind-body practices later. So I want you to think of those and how they can help you with sleep as well. And then finally, there are, of course, the pharmacologic therapies, which are medicines, can help with sleep. And usually our first line is melatonin, which is just an over-the-counter medication. But we always want to start with these other practices first. And hopefully you were able to join Dr. Lanoy's talk on sleep at the end of June, which talked a lot more about this stuff in depth. And then depression can actually also contribute to your pain experience. So again, a catch-22. So depression can worsen chronic pain, but chronic pain can contribute to low mood. However, it's very important that we're screening patients for depression. It's not uncommon to have low mood, even if it's just short term while you're going through a cancer diagnosis and treatment. So if you're experiencing low mood, I definitely encourage you to talk to your provider about that, because there's really good treatments. And the good news is that some medications to treat depression also can help with pain. So if you talk to your provider about that, they might choose a medicine that can help with both versus a medicine that perhaps only helps with pain. And again, the mind-body treatment is imperative when it comes to treating depression as well. And again, we're going to get into more detail on those. So let's start talking about some cancer pain treatment options. And as we're going through this, I want you to think about developing your toolbox. And I say that meaning, okay, your cancer pain is an experience and it changes. It can change day to day. It can change month to month, year to year, depending on what you're going through, what your treatments are, et cetera. So you need to have a toolbox that you can pull from depending on what the situation is, depending on how severe your pain is. And as we go through all of these things, I want you to know, what do you want to include in your toolbox? So medications are one option. So they can be useful for both acute, short-term, and chronic, long-term pain. You might need multiple different medications to get adequate relief, and that's not uncommon. There's some medications that last longer, or we use more for maintenance medication. And then there's short-acting medicines that we use for what we call breakthrough pain. So you might be on a medicine that lasts in your body a little bit longer. And then you might also have a medication to help when that pain spikes. So normally we want to keep pain at a nice, steady, tolerable number. Number meaning like a scale of 0 to 10. We usually work with you to say, what's a tolerable pain level for you? And we always want to keep it around there. But sometimes things happen and your pain can spike. And so that's called breakthrough pain. And we usually make sure that patients have medications for that potential breakthrough pain. Medications are best when they're used in conjunction with non-pharmacologic therapies, so non-medicine therapies. And the goal with medication is to use these for the shortest period possible. And I am going to talk more about that in depth a little later in the talk. And then also options to put within your toolbox, which we're going to talk a lot about, are non-medication treatments. And these non-medication treatments address the unpleasant physical and psychological consequences of pain. And these are generally very low risk. So we always want to make sure we're including these in our toolbox. All right, So pharmacological treatment, which is medication treatment for pain. And it's very important that before I start talking about the treatment of pain, that we understand the goal of pain management. And the goal is to bring pain to a functional level. It's not realistic to have a goal of pain being completely eliminated. And that's with any type of pain syndrome, whether that's cancer related or non-cancer related. And so the goal is to bring pain to a functional level. At what pain level is functional for you? Some evidence shows that really we're looking for a 30% decrease in pain levels. So I just want to make sure everyone's on the same page and that we're realistic, that we really want to make sure that you can function, but bringing your pain to a 0 is not generally realistic. That would be ideal, but not generally realistic. So some different medications for pain, a couple of these you've probably heard of. So Tylenol, also called acetaminophen, is a generally safe medication for most patients to use even during cancer treatment. NSAIDs, or non-steroidal anti-inflammatory drugs, are things like ibuprofen, Aleve, and these medications, generally, if you're getting chemotherapy, we don't use because it can it can increase your risk of bleeding. But that's something you can talk with your provider about. And then there's opioids, which I'm sure most of you have heard of, especially in the news and whatnot. So opioids are those medications, morphine, Percocet, oxycodone, fentanyl. Those are all fall within the opioid class of medications. And then for that nerve pain, that usually needs to be treated a little bit differently. And for these, we use different antidepressants and actually also some anti-seizure medicines. And I would be amiss if I didn't talk about cannabinoids. This always comes up in every talk I give about survivorship. So I do want to give a quick note that the evidence, of course, is still mixed and controversial as far as using cannabinoids for pain. When I say cannabinoids, I'm talking about marijuana, basically, in a nutshell. And there is some evidence, however, to show that it can help with that nerve pain. And there's some evidence to show that it can help with nausea and vomiting, which isn't what we're talking about today. But what I'm hoping is that as it's starting to become, the legalization is starting to become more widespread in the United States, that will allow more researchers to do some studies to see how it can help patients that have cancer pain. So as of now, there's not great evidence for us to be able to give recommendations for this class of drugs. There's some good research going on in Europe that I'm hoping can get transferred over to the US so that we can maybe get a head start on this for patients. But as of now, your provider won't be able to give you any good, sound, evidence-based recommendations. But if it's something you're interested in, I would definitely encourage you to talk with your provider about it, have an open dialogue. It comes up pretty commonly, as you can imagine. So just want to make sure you feel comfortable bringing that up with your provider. Okay, so we're going to spend a little bit of time talking about non-pharmacologic or non-medication treatments. And so the first one we're going to talk about is acupuncture. And you may have heard of this. This originates in ancient China, and it involves pricking the skin with needles. So if you have a needle phobia, maybe not your best option, but it has been shown to be helpful in patients with chronic low back pain, chronic headaches, and migraine headaches. And it can also help with nausea. Cold and heat therapy are really good go-to options that are cheap and easy and generally well tolerated. So cold therapy helps by reducing muscle spasms. It can reduce inflammation and it can reduce swelling. So that can be helpful. And then heat therapy improves blood flow and relaxes muscles and ligaments. And so again, very cheap and easy therapy. You don't need a prescription for those and you can use them at home. The one thing I'll just caution is that with heat and cold therapy, those sorts of things aren't to be used constant. You need to make sure you're doing that sort of intermittently or taking breaks with that as well. And then just let your provider know cold therapy helps you, heat therapy helps you, and then that just kind of helps them to know what helps you. All right, therapeutic exercises, and perhaps one of my favorite categories. So therapeutic exercises may reduce symptoms of distress and improve quality of life. And this has been shown in evidence. And these include things such as physical therapy and occupational therapy. And physical therapy and occupational therapy are great because it improves physical function in a safe way. And you would work with specialists, PT and OT, that will do an assessment and individualized treatment for you. And they work with you based on goals. And it's also very realistic, and they do really frequent check-ins. And however, it takes effort. And most of the things in this non-pharmacologic or non-medication treatment toolbox requires effort. And it's important to put that effort in. So PT and OT has shown to have small to moderate improvement in chronic pain and disability. And I utilize PT and OT a lot in my patients that have pain. And I can tell you that it has been very helpful. Yoga is something that doesn't require a prescription. By the way, PT and OT does require a prescription. So if it's something you're interested in, then just your provider, I guarantee, will be very pleased to put that in for you. Yoga you can do at home. And also through our integrative health program, which Susan introduced earlier, they do yoga classes. So, and this is also free. And so yoga's been shown to reduce fatigue, to improve sleep, and to improve pain and function. So that's like quite a few things that can be improved from yoga. So if you've never tried it, I would definitely encourage you to consider it. And the yoga through the integrative health program is with people that have similar backgrounds and diagnoses. And it's a really safe beginner place to start yoga. So I encourage you to look into that. Tai Chi is a very relaxing type of exercise. Some people say it's meditation with movement. And it has been shown to improve pain and function and also reduce stress. Aquatic exercise is exercising in a pool. And this is generally helpful for people that have joint pain. And then massage. We all like massage for the most part, but it actually has some medical benefits as well. And it may reduce pain, anxiety, and stress. And that's a picture of Tai Chi down there, by the way. Yes, thanks, Melissa. All right, so mind-body therapies, and this is Susan's baby, Susan who introduced me. So cognitive behavioral therapy can help with a number of things, and pain is just one of them. And what CBT does is it addresses the way we think, and it focuses on correcting the maladaptive or basically unhelpful ways that we respond to pain. And it can overall reduce the severity of painful symptoms, and then also useful in improving sleep. So cognitive behavioral therapy does require a trained specialist, usually a psychologist, to work with you on these things. And what it does is, and mindfulness is that we're going to talk about next and can be incorporated in CBT, is it really retrains the brain on how you respond to pain. And it might sound silly, but it's very effective. And just kind of thinking of, I recognize I'm in a lot of pain. I'm in control. I have all these things in my toolbox. I'm able to recognize that, pull from my toolbox, treat the pain that I know and expect because my physician told me I would get it, that I would have pain, treat the pain, try not to get really worked up about it, and then move on from it. And so it's kind of a way to staying in control. And that's just one example. And I'm not an expert in CBT, but I have seen it work in a number of ways. And like I said, pain is just one of them. And then there's mindfulness-based stress reduction. And this has also shown to be very helpful, especially when it's compared side by side with patients that don't do any type of mindfulness-based practice. And so this is being aware of one's physical, emotional, and mental condition at the present moment. So a lot of times if you have ever practiced yoga, for example, that meditation aspect of it is clearing your mind. If a thought comes through that's negative, or maybe you're like, oh, I'm worried my pain's going to get worse. Anticipating a lot of pain can actually contribute to your pain. So just being present, being aware of your body, listening to your body, and being able to be in control of that. That can be incredibly helpful, including deep breathing exercises. And Susan, who I like to bring her up a lot because this is where she specializes. She actually does one-on-one treatment for patients with mindfulness-based practice and deep breathing. And so at the end, I'm going to give you her email if you don't already have it. So if you're interested in including this in your toolbox, then you can reach out to Susan. So any treatment, regardless of what it's for, carries risks. So it's really important that once you decide what things you want in your toolbox, that you have a risk-benefit discussion with your healthcare provider on what would be best for you. Do they agree that these few items in your toolbox makes the most sense for you? Or maybe they have some input or different experience with patients that have gone through a similar treatment regimen or type of cancer. You never want to try something without first consulting with your healthcare provider, especially if you're on active cancer treatment. And I mention this specifically because a lot of times things on the internet can be enticing, and there's people out there that will try and sort of sell things to patients with cancer. And I encourage you to always, before you consider anything, talk to your provider about it, especially when it comes to things like supplements. There's potential interaction with things with your chemotherapy, for example, where it can make your chemotherapy less effective or maybe more effective. So not working as well or potentially causing toxicity, which we don't want. So anytime you're thinking of doing anything related to your pain or treatment of cancer, please talk with your healthcare provider about it. And I also want to mention that some treatments aren't covered by insurance. And things such as massage and acupuncture generally might not be covered by insurance. So that carries an out-of-pocket cost if that's something you were considering into your toolbox. And unfortunately, even some pain medications can be difficult to get covered. So here on our end, as clinicians, we have to fight the insurance companies to say, yeah, my patient needs this. So sometimes you'll have to remain a little bit patient while we work through that process for you. So I want to next go into talking about opioid use. And I bring this up, I want to emphasize this for a couple reasons. One is I worked as an oncology nurse for a long time, and I saw a lot of times where family members didn't want or almost wouldn't allow their loved one to take opioids because they were so worried about addiction. They've heard about addiction. And I just want to mention that if your physician tells you that for the severity of your pain, you require opioids to be in your toolbox, it's okay to take the opioids as prescribed. It doesn't mean you're going to become addicted. You're using them appropriately. So I encourage you and your family members to understand that. And if you have that concern, you can have that talk with your provider. I also bring it up because I have also seen patients develop issues with opioid use after being on opioids for a long time. And I have a particular passion about helping these types of patients. So I want to go through some definitions just to help you better understand some terms related to opioid use. So tolerance. Tolerance is when the body becomes adjusted to the opioid dose, requiring higher doses for the same effect. So if you have to be on opioids for a long time because you have severe cancer pain, eventually that same dose isn't going to provide that same effect. And that's inevitable. That's going to happen to you. It's going to happen to me. It's going to happen to the person next to you. And that's just how it works. Your body gets used to it. It develops a tolerance. And if we want to get that same pain relief effect, you have to have more. And that's just how it is. Dependence is when your body is used to having the medicine. So if you use the opioid over a long period of time and you stop taking it abruptly without a tapering down, then you can have withdrawal effects. That doesn't mean you're addicted. That just means that you have physical dependence. And that happens when you use opioids for a long period of time, even if you're using them as intended, as prescribed, and not misusing them. It's just how it is. It's just how our body is. So that doesn't mean you're addicted. It just means you have to taper the medicine over a period of time, which you would work with a provider on. However, addiction is when the opioid is no longer used for its intended purpose when they're used despite a high risk of harm, and when the user is no longer in control. And so you can see that's a big difference than tolerance and dependence. Tolerance and dependence can happen no matter what. You're using them as prescribed. That's just how it is. That's how our biology of our body works. Addiction is when things get out of control. When you no longer have that control, you feel like, I need my opioids, I need more. And then unfortunately, sometimes this leads patients down a bad pathway. So there's a risk of opioid misuse and again, this isn't super common, but we see it. So I don't want to not talk about it. And there are known risk factors that can put you at a higher risk of developing that opioid misuse down the line. And it can happen even if you began using them correctly. You know, you hear these stories on the internet or on the news, how patients started off, they had a back injury and they were on opioids, and then that just led them down a bad path. I'm not saying that's going to happen to you. I just want you to be aware that it does happen to some people. So it's important to know that risk, partner with your healthcare provider to prevent that from happening if you feel concerned about it. And if you have risk factors, which we could discuss if you visit us in clinic. Just like I had mentioned earlier, the goal is to be on medications, in particularly opioids, for the shortest period possible to prevent this risk. If you no longer have severe cancer pain, you've graduated. You no longer need opioids. And so it's important that we're using them appropriately. And I encourage you to advocate for yourself in that way, to say, you know what, I don't think I need opioids anymore. Can we just try other less potent medicines like Tylenol, for example? If you're concerned that you may be misusing opioids, it happens. And I just want you to know that there's very effective treatments and great support, even right here at VCU. A clinic called Motivate Clinic here, the number's listed there, and they can help you right away in getting and helping you work through that. So I want to end with just mentioning some resources that you can tap into to be able to fill that toolbox. So I mentioned Susan a lot. And so the integrative health program has vast resources to help you with all things, whether that's the yoga, the mindfulness practice. If you're interested in learning more about general health and wellness related to living with a cancer diagnosis, the integrative health program is your go-to place. You can email Susan at susan.chandler@vcuhealth.org. You can get on our mailing list to make sure that you're getting all these different seminars and whatnot, so you know what's going on and what is free for you to access. The Survivorship Clinic is where I'm at, and with Dr. Hong and Eunice. And if you'd like to make an appointment with us to talk about anything we talked about here today, or anything at all related to your cancer diagnosis, we treat a vast variety of things, and we'd be happy to do a consultation with you to see how we can best help you. Our number for new appointments is listed. The Supportive Care Clinic is also a great resource for pain, especially. They are experts in treating pain and also other symptoms from cancer treatment. So if you're suffering from severe nausea and vomiting, or fatigue, or weight loss, they can help work through all those things with you as well. The Department of Psychiatry is where you want to call if you're interested in that cognitive behavioral therapy, which I strongly recommend. Again, it is a commitment, but it's only going to help you in so many ways. A great thing to have in your toolbox. I didn't put the resource for physical and occupational therapy on here because it does require a referral. So again, if you're interested in that, then let your provider know, and I guarantee, like I said, they'll be happy to put that referral in for you. One other resource I didn't mention today, because it's more related to non-cancer pain, is our interventional pain clinic. So if you're interested in learning more about that, you can look that up on the VCU website, interventional pain or chronic pain management. That's more anesthesia practice, where they do different types of injections and things like that. So I didn't mention that because it's not necessarily related to treating cancer pain, but I do want you to know that's another pain management resource here at VCU. And at this time, I would love to hear if there's any questions. Again, there's my email. If you have any questions particular for me, or if you didn't feel comfortable talking about it today, I'd be happy to have a call with you, or like I mentioned, you can make an appointment with us as well.
Thank you, Jodi, for that very comprehensive review of strategies for helping to manage pain in the cancer experience. And I just want to say I'm so glad that you went above and beyond just prescriptions or management by pills, because obviously there are many things that people can have in their toolbox, as you use the term, that are effective. And that the goal is not to completely erase the pain, but to make it functional and manageable. Do you want to comment on that?
Yeah, so I encourage you, in a lot of times in healthcare, and I understand we're all busy, we've got a lot going on, and a quick fix is easiest. These non-medication treatments take time and effort, but even once you get past your cancer treatment, they will continue to help you. All of these things that you learn and practices. If you learn mindfulness practice, well, that can help you down the line if another stressful thing comes up. So it's in your forever toolbox to have those sorts of things, practice those sorts of things. And we're in no way saying medications aren't good options. Medications are usually necessary to treat pain, especially if it's that acute pain. But I just want to emphasize that it shouldn't be the only thing that we're doing in treating pain.
Absolutely. And on the other end of the spectrum, I do hear from patients and family members that when opiates are indicated, that they're so afraid to use them. And that's really a shame, because in those cases, we know that it can provide that temporary relief to get them through.
Yeah, and that's why I mentioned that specifically, is I've seen that in my especially in my nursing practice, when I used to work a lot with advanced cancer patients, that the patients just weren't taking their opioids because their family wouldn't really let them. And it requires a lot of education. And that's why I think it's important to know those different terms as it relates to using opioids, that it's not addiction until you're starting to have those behaviors that are abnormal, which are easier to identify. You would know if you're starting to get down that path, if you're, truthful with yourself. So if your provider prescribes you opioids and it's indicated for your cancer pain and you're still concerned about using them, then talk with them about it. But the goal is to get your pain down to a functional level, like I mentioned. And sometimes, and oftentimes with cancer pain, that requires opioids.
Yeah, I've never heard anyone really address tolerance and dependence and define them separately from addiction. So it's almost like with that understanding, you can understand the permission to use opioids safely.
And a lot of times we have to give that permission as the clinicians to say it's okay. And a lot of times those patients are like, I want to get off of them as soon as possible. And that's a great goal. But short term, you might need them.
Yeah, absolutely. And then the other thing I wanted to comment on was you listed the therapeutic exercises, physical therapy, occupational therapy. I think that's vastly underutilized in terms of pain management.
It is, and it's incredibly helpful, not only for cancer-related pain, but for other pain syndromes, whether that's knee pain from arthritis, whatnot. When you isolate those muscles that are supporting that joint, that can help relieve pain. And so that's why it's important to have these specialists individualize their care for you. A lot of my patients that have chronic pain after their cancer's gone, this is one of my first go-to things, is we got to get you into occupational and physical therapy. And I promise you it's helpful. Right before this talk, I had a note that a patient was getting signed off from PT and OT because she met all of her goals. And I see that over and over. So it's working.
Absolutely. And also it can work to help prevent pain as well as resolve it.
Exactly. So when I'm seeing a patient right up front and I know they're going to have a really hard cancer treatment, a curative patient that needs chemo and radiation and maybe surgery, it's really easy to get deconditioned, to lose weight, to have a hard time with eating. Well, if we can intervene early and have you working on your physical health, your diet, and keeping up those protein levels, it is immeasurable how much that can help you.
You also mentioned Dr. Autumn Lanoy's presentation about sleep and the
Yeah.
cancer experience. And I'm not sure if it's been posted on the Massey Integrative Health website yet, but she gave a very comprehensive and informative presentation about sleep. And I love that you mentioned that right up front, that the lack of sleep and poor sleep hygiene can really contribute to the pain experience, and it doesn't have to. That's something that we have under our control, whether it's cancer or not. So yes, be looking for that. I'm sure it will be posted soon if it's not already up there. Well, Jodi, thank you again for sharing such a wide array of treatments and options, because we know that this doesn't have to be a part of the experience that is uncontrollable pain or unmanaged pain. So in your final thought today, what is one thing that you'd like to leave listeners with?
So my challenge to all of the listeners is to think about all the things we talked about today and what you think would be best for you to have in your toolbox, and to potentially go outside of your comfort zone and maybe think about trying some things that you hadn't considered before or that you hadn't known much about before, and even look further into them and come up with your toolbox list and then talk with your provider about it and see what their thoughts are.
Thanks so much, Jodi. Really appreciate your time and your expertise.
Yeah, thanks so much, Susan. It's my pleasure.